All right, welcome back, coders, healthcare professionals, and students, to this explainer. Today, we are decoding the exact mechanics of pediatric and neonatal critical care billing. Look, if you've ever stared at a NICU or PICU chart and just felt completely overwhelmed by the coding rules, well, you are definitely in the right place. We're going to break down one of the most complex, high-stakes areas in the entire CPT manual. So let's just jump right in. We've got a really packed syllabus for today's masterclass. We'll start with number 1. Global daily versus hourly codes. Then number 2, critical care by age. Number 3, intensive care by weight. Number 4 covers pediatric critical care transport. And finally, number 5, bundles and concurrent care.
Okay, Section 1, Global Daily versus Hourly Codes. This is a massive paradigm shift.
To get this right, you literally have to rewire your brain when you transition from the adult ICU to the pediatric side. Think of adult critical care like a taximeter, right? It bills hourly. You use CPT 99291 for the first 30 to 74 minutes, and then that add-on code 99292 for the extra time. But pediatric and neonatal critical care? That is way more like a hotel room. It's billed as a daily global package. The CPT guidelines tell us that these codes include all the critical care rendered by the directing physician on that specific calendar day, completely regardless of the total hours spent. So, stop counting minutes. You are billing for the overarching management of the entire day.
Moving right along to Section 2, Critical Care by Age. Let's categorize these brackets.
Now that we know we're billing per day, we have to look directly at the patient's age to lock in the right code. First up, the neonate. That's defined as 28 days of age or younger. They get CPT 99468 for the initial day and 99469 for subsequent days. Next, the infant bracket. This spans from 29 days up through 24 months, using 99471 for day 1 and 99472 after that. Finally, the young child bracket covers kids ages 2 through 5 years old. Their codes are 99475 for the initial day and 99476 subsequently. Oh, and as a quick aside, once a pediatric patient hits 6 years of age, you just revert right back to those hourly, time-based adult critical care codes we talked about earlier. Take a look at the actual CPT language highlighted here. To legitimately use these codes, the patient absolutely must meet the strict definition of being critically ill. The clinical criteria require high-complexity medical decision-making plus direct cardiac, respiratory, or vital organ support. Basically, a critical illness has to acutely impair one or more vital organ systems to the point where there's a high probability of imminent life-threatening deterioration. You can't just use these codes because the patient physically happens to be sitting in a critical care unit. The clinical condition itself must demand it.
All right, Section 3, Intensive Care by Weight and Dealing with Frequent Interventions.
So what happens when an infant requires a ton of frequent interventions but, doesn't quite meet that full definition of being critically ill? Well, that's exactly where intensive care codes step in. They capture that intensive observation phase. These are patients who need continuous monitoring, constant vital sign checks, maintenance of nutrition, and close observation. They're sick, for sure, and they need high-level resources, but they aren't in imminent danger of vital organ failure.
How do we start billing for this? Well, the initial day of inpatient intensive care for a neonate, again, meaning 28 days of age or younger, is always billed with CPT 9947. It actually doesn't matter what the baby weighs on day 1. If it's the initial day of intensive care for a neonate, boom, 9947 is your code.
However, for subsequent intensive care days, things get interesting. We switch entirely from age-based coding to weight-based coding, so you must look at the infant's present body weight for that specific day. If their present weight is less than 1,500 grams, you use CPT 99478. If they're between 1,500 and 2,500 grams, it's 99479. And if they weigh between 2,501 and 5,000 grams, you report CPT 99480. You really have to keep an eye on those scales, because as the infant grows and gains weight during a long NICU stay, your billing codes will literally transition up through these tiers.
Section 4. Pediatric Critical Care Transport, focusing on interfacility care.
Now let's shift gears to a super high-risk scenario, which is physically transporting these vulnerable patients between facilities. When a physician provides direct, face-to-face care during the transport of a critically ill child who is 24 months of age or younger, our billing mechanics change completely again. Because this takes the physician out of the hospital and isolates their attention entirely on this single fragile patient during a transfer, time-based mechanics actually come back into play.
So, here is how you calculate it. You're going to bill CPT 99466 for the first 30 to 74 minutes of hands-on transport care. If the transport takes longer than that, you'll use the add-on code 99467 for each additional 30-minute block. But keep in mind, if the face-to-face transport time is less than 30 minutes, you can't use these codes at all. You would just use standard EM codes instead.
Notice the really specific guardrails highlighted in the manual here. It explicitly notes that this only counts for direct, face-to-face time with the patient during transport. The clock starts when the physician assumes primary responsibility at the referring facility, and it ends when the receiving facility accepts responsibility. And this is crucial. It does not include the time spent on the phone making arrangements or communicating with the transport team before the actual physical handoff. Direct, hands-on time is the name of the game here.
Finally, Section 5, Bundles and Concurrent Care, or How to Avoid Claim Denials.
This right here is where claim denials happen the most frequently. It's the biggest gotcha for auditors. Because these daily global codes pay so highly and account for incredibly intensive work, they bundle in a massive list of procedures. Just look at this list: endotracheal intubation, umbilical artery or vein catheterization, CPAP, surfactant administration, lumbar punctures, and even the monitoring and interpretation of blood gases. The absolute vital takeaway here is that you cannot bill these procedures separately if the primary physician is reporting the daily global pediatric or neonatal critical care code. They are already baked right into the reimbursement.
Let's also talk about concurrent care. The CPT guidelines dictate that only the primary directing neonatologist or intensivist reports the per-day global code. It can only be reported once per calendar day per patient. So what happens if the baby goes into renal failure and a pediatric nephrologist is called in to co-manage that specific organ system? Well, that specialty consultant cannot bill the daily global critical care code. Instead, they have to use standard EM codes or the time-based adult critical care codes, depending on their exact level of intervention. The global package belongs strictly to the primary directing physician. I hope this explainer completely demystified these complex age and weight-based guidelines for you. But it really begs a bigger question. As neonatal technology advances and survival rates for micro-preemies keep improving, how will the CPT manual have to adapt these weight brackets in the next 5 years? It's something to think about, so keep an eye on future updates. Until then, don't forget to like, share, and subscribe to Decode Healthcare with Harshal.